I think let's keep moving ahead. And next is, I think, Dr. Debopriyo. Debopriyo, are you here? Please share your presentation.
So I will share my screen on his behalf.
Good morning. Good morning, sir.
Hi, Dr. Debopriyo, welcome. It's your first time here.
Thank you, sir. Yes,
And
sir. This is the first time I'm presenting in Acardmy, and beautiful cases, sir. The last few cases were absolutely mesmerizing. And with your due permission, sir, I'll start my case. Sagar, on my behalf, will present the slides, and I'll go through my case in the next 10 minutes, sir.
Yeah, please do.
Okay, so next, move to the next slide, Sagar. So the case history is he's a 65-year-old gentleman who underwent a CABG in Bangalore in 2012. And subsequently, after a couple of years, he had developed angina, for which he had gone back to the Mother Institute. Angiogram done revealed an LCX which was subtotally occluded. So they did a stress imaging and then subsequently told him to keep on medical follow-up. And now in 2025, when he presented to me, this time he had climbed on from being a normal asymptomatic individual to becoming a functional class 2 to 3 NYHA angina on exertion. ECG was substantially normal. Ejection fraction was fair enough, around 50 to 53%. This time again, he underwent an angiogram at a separate center, and he came to me for further management. So this was the basic history. And on seeing the angio, what we'll see is the next slide. Next slide. So this is the baseline coronary anatomy. He has a diffusely diseased left system. The left main is diseased. The proximal LED is calcified, diffusely diseased. The distal LED is totally occluded. And we have a distal LCX, which is having a TIMI1 like flow without any proper visibility of the proximal LCX. Next. And in this RAO caudal view, what we see here is, if we see carefully, that there is a extensively calcified on normal fluoroscopy. It's a densely calcified, or what we define as a severely calcified LCX with a totally occluded from origin. Only there is a faint flow noted distally. This could be a homocoronary collateral or probably some collateral which is coming from the left system via the Lima to LAD graft. So the grafts, what has happened was the Lima LAD graft was patent, and the graft from the SVG to OM got occluded. Patient was somehow asymptomatic for all these years, but now he has become significantly symptomatic. And the graft angio revealed that the ostium of the LCX graft was occluded. Hence, there was no option of doing any graft angioplasty. And as we all know, that the better option of doing a case is doing the native vessel angioplasty rather than doing a graft vessel. So the planning started now, henceforth, that what will be the calcium modification strategy and what would be the likely steps involved. Now, thinking of this, the first thing is we don't need a nuclear imaging to define the strategy because he's already symptomatic. His ejection fraction probably has dropped a few points, but it is still on the normal side, and he's otherwise very stable. So thinking of the calcium strategy, what I thought was, the good strategy, if the wire crosses, would be doing an orbital atherectomy, because it will give us all the 3 layers of protection. Because in this case, the most important thing to be kept in mind is, since it's a post-CABG, getting a cardiac coronary perforation would be life-threatening because there is no pericardium. Everything will go into the mediastinum. So keeping the strategy simple and safe would be the first priority. So I went ahead with a normal orbital atherectomy in this case. And next slide would be next. This in various views, what we see is trump track calcification, and then we cross the lesion. The first thing was crossing the lesion itself was not very easy. What I thought it would be difficult, but subsequently it crossed with a Filter XTA wire. Next. So these were the consumables, and obviously since the right side was non-dominant, we didn't do anything on the right side. So guide catheter selection was a 7 French EBU. We took a 1.8 French fine cross micro catheter, and it crossed with a Filter XTA wire. Next. So after crossing the difficult part of the lesion, which I thought would be very difficult in crossing, but then subsequently the Filter XTA, as it found a microchannel, it crossed distally, and then we exchanged it with a Viper wire. And then we switched over directly into taking the orbital atherectomy tool. We took the bar inside. Next. What I felt was there was an initial jerky motion when I started off with an 80,000 RPM. It actually dived inside, which is probably would have been a obstacle if I would have used rotablation, which it would have got stuck probably. And then subsequently, with multiple runs, it went inside into the most calcific lesion. I did an IVUS. I'll show the IVUS next. IVUS. Show the next slide. And before putting in the orbital atherectomy catheter, the imaging catheter could not cross. So the IVUS imaging could only be done after first 3 or 4 runs of 80,000 RPM. And the principle utilized here was all the three principles of an orbital atherectomy. We actually differential sanding of the dense calcification. We create enough lumen, and also we change the compliance of the vessel. So therefore, it actually takes care of everything if we do it gradually, step by step. So we also achieve a adequate lumen area, what was evident in the later part. Show me the IVUS. Next slide. So this was the IVUS done to LCX, and the measured MLA was 2.96 millimeters square. This was the tightest part, and this was done after the initial runs with the orbital atherectomy. The initial runs actually give us a particular sound change from what we always see, that there was a definite change in the sound, which we usually tend to hear from a normal segment to a moderate calcifium to a severely calcified segment. And as I was coming up from the distal part of the LCX to the ostium of the LCX, there was a typical high frequency sound what we encounter in a severely calcified lesion. So initially what I did was again, one more advantage what I faced here was I initially went down and I came up in the retrograde fashion with 80,000 RPM. And after doing that repetitively, coming back from the distal part of the LCX, I could create a good lumen area. And then once I went up till the LCX ostium, I had to increase the speed to 120,000 RPM, and that to again 4 to 5 runs. So after giving a total of 8 to 9 runs, I again utilized my IVUS. Next slide. So this is after doing the IVUS. I knew that there is a definite sanding effect. The lumen area achieved was good, and there was definite breaks in the calcium. There was definite increase in the overall lumen area. So I further pre-dilated with an NC balloon at 16 to 18 atmospheres. Specifically the ostium, because I had to deliver some more debulking strategies like a cutting balloon to achieve more lumen area before I decide whether to stent it or to go ahead with a drug-eluting balloon. So after dilating with the NC balloon, next slide. I used a Wolverine 3 millimeter cutting balloon at 12 atmospheres. I went on initially very slowly because this was the Achilles heel of the procedure, what I feel. Because anything goes wrong in the severely calcified osteal LCX lesion, there would have been a tamponade, and which could be very, very difficult to manage given a post-CABG status with the pericardium being stripped off. So very carefully, I slowly inflated, checked in the 2 orthogonal views, the the position of the balloon and the inflation pressures and the inflation shape of the balloon. And I slowly went up to 16 atmospheres. Now, the selection of the size of the balloon, the vessel size was almost 3.5 millimeter. So if I have to remain safe, so probably taking a 3 millimeter cutting balloon would be a safer option than going to a 3.25 and never a 3.5 balloon. So that was the reason behind why I chose a 3 millimeter cutting balloon. After the cutting balloon, the angiogram showed a reasonable angiographic lumen area. And after the bed preparation, this was the angiogram which showed even now the ostium looked like severely calcified. And probably looking back, what I think was I could have probably used other high pressure balloons like an OP and NC balloon, but I could not use because of that time. I told the patient that these were the hardwares we could have been used, and we had to face some difficulty in convincing that more hardwares needed to be used. So with this, I again, next. I thought that what should be the next step? Should we deploy a drug-eluting balloon utilizing a 3.5 millimeter DEB, or DES would be better? So since I have achieved a good sanding effect, an adequate lumen area was achieved, I thought that giving a stent would be better in terms of long-term vessel area, because we're going to tackle the LCX ostium. Secondly, the decision what I had to make was whether I'm going to stent across the left main. Now, the only issue what I thought was, if I have to stent across the left main, then I have to also take care of the proximal LAD, because proximal LAD, the ostium part was severely diseased and calcified. Now, doing that again would make the process more complicated. Since we already have a good limit to LAD filling, so I thought that probably an ostial LCX stenting would take care of the system rather than going into making more complex and increasing the number of hardwares. So I deployed a Zions Alpine stent, 338 millimeters, positioned at the ostium and deployed at 16 atmospheres. So the stent deployment, during the deployment, the boost showed almost good deployment in the mid part and the distal part of the stent, but the ostium of the stent actually did appear slightly under deployed. So IVUS was done in after the stent deployment and after the initial post dilatation, which showed next. The IVUS derived LCX area in the proximal LCX was just 5.66 millimeters square. Now, according to the Kang's criteria, the classical criteria, what we have already studied and known is 5, 6, 7, 8. So I could achieve 5.66 millimeters at the ostium, and the distal LCX was fair enough with a 6.37 millimeters square. Now, actually, I used another NC balloon to further optimize the proximal part of the stent, again keeping in mind that too much of aggression at the ostium could probably jeopardize the entire strategy, and I could land up in soup if I don't stop at a certain point of time. And then looking at the age, he's 76 years old. I have achieved adequate lumen area as per the standard criteria. And then we are not going to lose about the whatever ground I have achieved. I decided to dilate with an NC Trek Neo. The proximal part 3.5 and 8 millimeters went up to 20 atmospheres, and then subsequently took a shot. Next slide. This was the IVUS. IVUS showed a good lumen area in the distal part. There was no edge dissection. There was no intraluminal hematoma. The lumen area appeared almost circular without any cross-sectional area or elliptical shape of the vessel, giving, indirectly telling us that the calcium modification has been adequate in almost all planes. And as we climb up in the proximal part of the vessel, what we say is there is slightly distortion in the vessel anatomy, and this is because of the severe chunk of calcium which is present at the ostium of the LCX. Now, ostium, as we all know, is the Achilles heel, and we have utilized the cutting balloon. We have utilized high pressure balloon, the normal NC balloon at higher pressures. We have deployed a stent, and then I thought probably this is the time where I should call it a day rather than going into the probable complications. So next slide. So this was the final result. I achieved probably a decent result, given the background that this was present for the last 10 to 12 years, and now patient is symptomatic. And the blush, look at the blush is absolutely good. We get a TIMI-3 blush grade here in the distal part of the, suggesting it's a viable myocardium, and probably the patient is going to get a good result out of this. Next slide. And finally, the hemostasis was achieved by using a 8 French angioseal. There was no complications in the femoral axis. Next. So thank you so much for the patient hearing, sir. Probably the only take home what I could understand from this case was patient's CTO, when we were attempting in a calcified LCX lesion, probably discussing the patient about the pros and cons, specifically in a post-CABG highly calcified vessel, is very, very important, because the risks are very high. The innate intrinsic risks of complications are very, very high. And a 76-year-old is probably not going to tolerate any of the complications if at all it happens. And selecting the right hardware, giving adequate time and number of runs in an orbital is very, very important. And then stopping at the right point of time is also very important. Thank you so much. Thank you, sir, for the opportunity. Thank you again.
Thanks, Dr. Debopriyo. It was a nice case. I think you were really getting modest by saying a reasonable result. It's not reasonable. Result cannot be better than this. So it's a wonderful result. It can't be better than this. You know, given the circumstances, the way the vessel was totally occluded, calcified, ostial, everything. So it's actually a very exciting and fabulous result. So nobody can achieve a better result than this. So it's full marks to you. And I think just one statement which I'll give. Don't be worried of doing some aggressive post-dilatation at the ostium. Ostium behaves different as compared to the other coronaries. It has more muscular fibers. So I haven't seen ostial of any vessel getting a perforation unless you totally make your balloon size discrepant. You know, if you're dilating 3.5 and 2.5, that's a different story. But 3.5 going to extreme, this is a 3.5 vessel. So 3.5 balloon non-compliant, which is not growing, I think it's very fair, and you can try more pressures at the ostium. So first 3 millimeter of any vessel is more resilient as compared to the other vessel. Thank you. Thanks for being here, Dr. Debopriyo. Keep visiting.
Thank you, sir.
This is a
Thank you. Thank
kind
you.
of, we try to have a platform where we discuss more freely and we keep learning from each other. So stay
Thank you, sir.
on the end. There is one more presentation I think that I have to do. Karthikeyan, you want to add, please add your statement.
No, sir. Thank you, sir. Nice presentation.